Hello and welcome back to Module 8. We're talking about the GI system. We left off on our last slide. I'll go backwards for you on emergencies after an endoscopy. So these were things, if the patient is vomiting, notify your doctor. Having difficulty swallowing, they're going to have a sore throat, but if they're having difficulty swallowing and pain when they swallow, notify the doctor if it's getting worse. Now, when they leave, your throat is going to be sore. But if it increases from what's going on now, they need to notify their doctor. Also, sometimes some anemia, just in case they did a biopsy and had a little bleeding, any unexplained changes in their bowel habits, any abdominal pain, especially any melena. We definitely need to let the doctor know because maybe something else is going on with them. Now let's look at some upper GI exams. Now, there is a series of x-rays used to help diagnose problems of the GI tract. So this is our GI tract, right? And we have a little picture over here. The barium test can be for upper GI, which is what? Your stomach, your esophagus, and your duodenum, upper stomach. Now, when we look at our upper GI, what are we doing it for? You ask yourself, why are these tests being done? I want you to look at the slide and look at all the things why the physician could be doing an upper GI on a patient. That's why it's always good to get your patient's history so you'll know what's going on with your patient. Okay, so then look at these, and these are what the upper GI exam can detect in your patient. So for prep, basically for upper GI, you want to have the patient NPO at least 8 hours before the procedures. A lot of times the doctors just tell the patients NPO after midnight, or if the procedure in the afternoon, they'll tell them nothing by mouth at a certain time. So these patients, you want the stomach empty so they can visualize much better. So a small bowel series, that's a barium test for small bowel, for the small intestines. So we talked about barium earlier, and you understand how when you drink the barium, I'm sorry, that medium is shown up on the x-ray. So when it doesn't show up, that means a possible block or something else is going on in that area. Esophageal manometry, we send our patients out for this. It's done as an outpatient basis. It does take about an hour for the test to be done. It has various sensors on it. I do have a video to show you, so I will try and incorporate all those videos in here so you don't have to go back and forth. And I'm hoping and praying that the volume from inside of the computer will work. Let's move on. So this is more of the manometry. The patient is NPO, the same as the other. They basically doesn't need any sedation at all. And any complications, always there's complications possible, but for this particular procedure, the risks are very low. So you do have the 24-hour pH monitoring also. Basically, it detects the amount of pH. So as we were looking at the video before, when the doctors complete the exam, you don't want a pH less than 4. Now, you may have different authors that may say different things, but they're detecting, and if there's any problems, that pH is really less than 4, and then they have to see what they need to do for these patients. Let's look at some GI disorders. How about constipation? So when we look in our syllabus, it does talk about constipation. Now, women and elderly are most impacted. So because our volume in our body is less, so we need to be diagnosed with constipation, you need 2 or more of the following for at least 3 months. So here they are. Okay, so then we know. So in our nursing assessment, we need to make sure that we continue to look at risk factors that the patient might have, what's going on with them. They might be on some aluminum salts, or because those are found in antacids, diuretics, Sometimes they're abusing laxatives. So even lack of exercise because we're not moving like we should. So these are all things that are risk factors for constipation. So manifestation. So basically, what are you going to see as a nurse? Oh my goodness, this patient abdomen is distended. Or some patients say my abdomen feels bloated, or I feel like I'm full of gas, or they're having pain in their stomach. Sometimes anorexia is a manifestation. Pain with defecation. So if they get really constipated, it's hard to push the bowels out. So here are some of the complications that you see over here: bowel obstruction and so forth. The hemorrhoids from hard stools pushing and pushing out. Sometimes patients have hernias, irritable bowel syndrome, and so forth. So constipation, if you look at page 1382, it does talk about some dietary management, pharmacological and non-pharmacological. So what about dietary management? We want to make sure we have foods high in fiber. Sometimes patients are on stool softeners, just different things. Please read that chapter reading so you can have a better understanding. Now let's move forward with some talk about diarrhea. They're watery bowel movements. Yes, they are. Symptoms usually last about a couple of days unless other things is happening with the patient. So if they're longer, they can, with the diarrhea, if there's more than those days, a couple of days, patients can start having blood and mucus, undigested food, fever, abdominal cramps, weight loss. So these are things that does happen. I didn't see on here, but that diarrhea can also cause a lot of dehydration. So those at risk are, of course, our little tiny babies, our very old, and those with major illnesses. So diarrhea risk factors. I don't know. There's so many diseases out there that cause diarrhea. You just can't say one particular thing causes diarrhea. Could be a problem with the GI system. Could be something you ate. It could be a virus. Different things causes. Like we said earlier, 100 plus diseases associated with diarrhea. But like I said about the virus, sometimes you have ulcerative colitis too, and then you can end up with blood in your stool. Cancers, stress, traveler's diarrhea. So all these things does happen. So here's some manifestations of diarrhea. You're going to have diarrhea. Some of the complications is what we talked about earlier, but look at the electrolytes. So as a nurse, we're going to look at the electrolytes and make sure our patients' electrolytes aren't getting too low. So we're going to monitor them for dehydration, monitor the potassium level, monitoring them for hypovolemic shock, checking their orthostatic vitals, checking sodium, phosphate, and magnesium. So these are things that we would do. So if patients were having a lot of diarrhea, this is some of the management that we would do. So you want to give them, and we spoke earlier, water. You don't have electrolytes in water, but you can buy some of those drinks that do have electrolytes in it. You want to have them with a salt broth, some vegetables. Hopefully some of those vegetables are high in potassium because like earlier we said we'll lose potassium. And you want to put the patient on the BRAT diet: bananas, rice, applesauce, and toast. So here are some of the farm management. So here are some of the medications that doctors order for diarrhea. So don't forget about those. And we talked about Pepto-Bismol in class. Don't forget about it. Pepto-Bismol does change the stool color. So make sure you let the patients know about Pepto-Bismol. Let's talk about hemorrhoids. They're unnaturally swollen or distended veins in the anal rectal region. So I do have a picture that's going to come up that's going to show you some hemorrhoids. Continue to read this slide so we can keep going on. But look at that prolapse of the vessels. Repeated elevation and pressure separate the distended veins from the smooth muscles. Okay, increased intra-abdominal pressure causes elevated venous pressure, and we end up having some hemorrhoids. These are some risk factors that are involved with hemorrhoids. And then also look at the manifestations. Patients are going to have pain. They're going to have pain in their rectal area. They're going to have possibly some rectal bleeding. Depends on how much trauma the constipation has caused it, when the patient are forcing their stools out or having a very difficult time of having hard stools. and other different things that could cause bleeding. Sometimes the hemorrhoids just have little bleedings on their own. Let's continue and let's talk about some complications. So for sure, pain. So we talked about pain in the past. So we have to assess the patient's pain, their pain level, describe their pain. If we need to do a visual assessment, this is what we have to do. Now here, this is a hemorrhoid, but it's a bleeding hemorrhoid. Okay, so for our dietary management, I spoke of earlier, we want to make sure water. Why? We want to continue to keep that patient hydrated. And then also, what else are we trying to do? We're trying to increase fiber in the patient's diet. So for farm management, here's some pharmacological management, and then here's non-pharmacological management. Look at those, okay? Irritable bowel syndrome, functional GI disorder, chronic, or is it recurrent? It can be either or. And then, in addition to the irritable bowel syndrome, patients do have the constipation, they do have the abdominal pain, the bloating, and all the others. Okay? Irritable bowel syndrome. Look at this picture. I wanted to show you guys this pulled straight from your book regarding irritable bowel syndrome. Look at the colon and look what's being irritated. You have spastic contractions of the colon as they occur with irritable bowel syndrome. So in patients with irritable bowel syndrome, bowel motility changes and increase or decrease bowel transit times results in the changes in normal bowel elimination pattern. When talking to your patient about irritable bowel, start assessing abdominal pain. Is it relieved by defecation or falling asleep? Abdominal pain associated with changes in the stool, frequency or consistency, and read the other bullet points. These are all important. So here are some non-pharmacological things. So here we go. You can teach the patient to avoid problems that stimulate, like foods that are they're not tolerated or exacerbated symptoms. Sometimes it's individual. Patients know that if I eat this particular food, this happens. You want to tell them to increase the fiber, increase water, keep symptoms diary. Basically, what are their triggers? What is it that I eat that starts on, that contributes to my irritable bowel syndrome that makes me have all my signs and symptoms? Here's more pharmacological. Look at these therapies. Bulk forming laxatives, Metamucil, antidiarrheal agents, which we talked about earlier. Let's now talk about appendicitis, and we'll probably continue this in part 3 for appendicitis. You know what? I think I will, because we don't have too many minutes left in this one, so I'll just make a part 3 on appendicitis, and please look over this, and I will continue with appendicitis part 3.